Hi and welcome to Physiotutors podcast episode 51 with Henrik Riel. Henrik is a physiotherapist from Denmark and has obtained his PhD in the management of plantar heel pain. He's doing a postdoc fellowship at the University of Aalborg, and he is an assistant professor at the physio department of the University of Northern Denmark. Hi Henrik, welcome to the podcast. It's an honor to have you.
Hi Kai, and thank you for inviting me to join the podcast and hopefully deliver some good information for you.
I'm sure you will. We have a lot to talk about, so I would like to jump right in with the first question, which is about terminology. Plantar fasciitis, plantar fasciopathy, or plantar heel pain. What should we call it?
Well, I'm not the one to decide what to call it, but I do have a suggestion. Because the condition has been called lots of different things over the years, and 300 years ago it started out by being called the gonorrheal heel. It's also been known as a policeman's heel because policemen were known for standing up for quite some time and having heel pain. So a few years ago we decided to publish an editorial to start a discussion about what terminology to use, because we don't necessarily know what is going on inside the heel of the patient. We don't know which structures are involved in producing pain. So what we suggested was to simply call this plantar heel pain, because that is what it is when we see patients when they come to the clinic. They just say that they have first step pain, but we don't know if it's due to the calcaneus, whether it's due to the plantar fascia. So based on that, if you palpate patients, take patient history, then we can just diagnose it as plantar heel pain. What we do in research is that we usually also take ultrasound scans. Then we measure the thickness of the plantar fascia, and if we see that the thickness is increased, then we at least know that something is going on inside the plantar fascia, and then we call it a plantar fasciopathy, because then we know it's pain that comes from the fascia.
Interesting. And how is a fasciopathy different from a tendinopathy?
Well, there are some similar traits. For instance, the fascia consists of the same fibers as a tendon. We do see the same changes inside the tissue when people have a fasciopathy compared to people who have a tendinopathy, but there are some structural and functional differences between a fascia and a tendon, as the tendon will attach muscle to bone, and the fascia doesn't attach muscle to bone. It's bone to bone. It connects.
Yeah, and so the difference is basically the attachment, and the structures or structural changes that we see are pretty similar in a tendon and in the fascia, right?
Yeah.
Okay. And is there a typical patient that gets plantar heel pain?
There are two archetypes or phenotypes of patients that have been described in the past. One is the runner, and those that are running quite a lot, who have a large running volume, and 8% of all running injuries are caused by plantar heel pain. So it's very common in running injury as well. And the other type that is being described is usually the middle-aged person. Usually they are female and obese or overweight. But there are so many other patient types that you will encounter in your daily life in the clinic. So you can't necessarily rule out the condition if you see that the patient that you see is not someone that you can put into either of those two categories.
Yeah, and you already mentioned overweight or being overweight as a phenotype, and also the running. Are there, or can we say those are risk factors? And next to those two, what does the research say about risk factors to develop plantar heel pain?
There was a systematic review that was published in the JSM. Maybe time is running, so maybe it's like 7 or 8 years ago now. I usually say that it was recently published, but I can't necessarily say that anymore. So what they did was that they looked into all of the different studies that have tried to identify risk factors for developing plantar heel pain. And then they divided them into two groups, one being risk factors if you are a runner and risk factors if you're not a runner. And if we look at those that are not runners to begin with, the only risk factor that they could draw any firm conclusions on was a high BMI. So if you have a high BMI, then you have a higher risk of developing plantar heel pain. Some of the other factors that they looked into, and some studies indicated that it was indeed a risk factor, while other studies didn't find that it was a risk factor, for something like limited ankle range of motion or abnormal foot posture. But the thing about the studies that have looked into risk factors among those that are not runners is that they are cross-sectional. So you don't necessarily know what came first. Was it the high BMI or was it the pain that came first? In runners, they have done studies that were prospective. So they had no pain to begin with. And then they looked into who were the runners who actually developed the pain and who didn't develop pain, and then looked into the differences between the two. And they saw that the more you run, the more years you have been an active runner, then you have a higher risk of developing plantar heel pain. If you run if you use running shoes with spikes, the one that you use in when you are running around a track, and if you have a very high foot arch, which just corresponds to a rigid foot, then you're also at a higher risk of developing plantar heel pain.
Thank you for your answer. It's interesting. And if we go or move towards diagnosis, so someone comes into your clinic with heel pain, what are typical signs and symptoms of plantar fasciopathy?
I think that the main sign is when we are asking patients about the pain, and they will complain of first step pain. So they experience like walking on pins and needles when they get out of bed in the morning, or when they get up after they have been sitting for a while. Then usually pain will then decrease when they start to walk about, and then they see later in the day, or if they've been walking or being active for quite some time, then pain starts to get worse. So you can say it's like they have a U-shaped pain pattern where the first step pain is very high, then the pain decreases, and then it gets worse over time with ambulation. So that's like the first indicator of plantar heel pain. Then
is there anything? Yeah, go ahead. I wanted to ask: is there anything else, or you do from that point you jump right into examination?
Usually, I'll ask about their the type of pain that they feel. Do they feel like it's a sharp pain, like walking on pins and needles, or do they feel like more it's numbness or paresthesia? And of course, if they don't say that their pain improves with ambulation, then I will ask them what they feel when then they get up and start to walk about, because that can also help me to distinguish between different conditions or differential diagnoses that could be present.
Mm-hmm. And would that be something like a tarsal tunnel or a sural nerve irritation? Or what kind of pathologies do you have in mind as a differential diagnosis?
It would be a tarsal tunnel or maybe Baxter's nerve compression. Could also be that, and then they would complain of like a numbness or paresthesia, or they feel that the pain runs either on the medial or maybe even to the lateral side of the foot. It could also be a fat pad related issue. And in those cases, a patient will say that, well, maybe the first step pain isn't that bad, but then it gets worse when they start to walk. And with the plantar heel pain or the plantar fasciopathy, we will hear that they say it gets better when they start to walk.
Yeah. Okay. And do you use any special tests, or what kind of examination do you perform in those patients?
I say that the main examination will be palpation of the plantar heel. Usually they will say that they are very sore or they're in pain when you palpate where the insertion of the plantar fascia is under the heel, on the calcaneus, but usually they can feel pain that also extends beyond the plantar heel. So not necessarily like a referred pain, but if it's not that localized, then you shouldn't start to rule out plantar fasciopathy, at least. I also like to do either the tarsal tunnel test or the triple compression test, and to test for the Tunnel's sign. And if we're in doubt after that, and if I don't think that this is necessarily just plantar heel pain, if I think that it could be something like Baxter's nerve or other nerve entrapment, and I'll do an ultrasound just to measure the thickness of the plantar fascia and see if the thickness is increased. And based on my experience, and also based on the research that we have done, because what we do is that we make an open invitation, so to speak. So if you've had pain for at least 3 months, if you feel like first step pain, we invite people in, and we of course, because it's in research, so we do the ultrasound scan, and we exclude very, very few patients. So if they feel first step pain, if they've had it for a few months, then in 80 to 90% of the cases, we also see that the plantar fascia has an increased thickness.
Mm. Okay, so you already answered my follow-up question, which was like, what added value does imaging have? So ultrasound might be of added value. Anything else? Because sorry to add on, because a lot of people are worried about their heel spurs, which we I think know of, and you can confirm this or contradict. The heel spur itself doesn't change anything, like when we look at the course or treatment.
Yeah, so it doesn't really change anything. It's not a prognostic factor, and it's just so it's I usually say it's not a diagnosis. It's an unimportant finding. So there are only 2 and 3 people who have plantar heel pain who also have a heel spur. So what it changes is the patient education and the information that you give patients. Yeah. If they know that if they have if an X-ray has been performed and they know that they have a heel spur, because then we need to tell them that it's not important and it doesn't change the way that we're going to manage the condition.
Yeah, clear. And if we go further and we look at the cause of plantar heel pain or the prognosis, I think I've heard you somewhere on a podcast or in a lecture, heard that you said only 40% improve, I don't know in which time frame, which I thought was surprisingly bad, actually. Yeah. Well, the prognosis isn't as good as we would like it to be. So it's based on a study from 2006, I think, from Di Giovanni. What they used was patient education, and they also used stretching exercises. And it was the study that I've encountered, at least, that had the longest follow-up time. So after 2 years, despite they had received good treatment, and only 40% were actually pain-free at the time. And would you say that it's due to the fact that it's a complex pathology, or is it due to bad management? It's a very, very complex
condition to treat. What we need to keep in mind is that when we look at long-term follow-ups of studies such as that one, I can't remember the exact in and exclusion criteria that they used, but usually patients will have to have experienced pain for a few months before they are included into these research studies. In my own studies, we've used a minimum of 3 months at symptom duration before they can enter the studies. So these are not the ones that we see in the clinics where they complain of pain for maybe 2 to 3 weeks or maybe for a month. And it's much more likely to resolve if we see them after they've only had pain for such a short period of time compared to in the research that we do. And those that we include into research, they will usually have tried different treatments before they are included. So what we are doing is that we are including some that are non-responders to at least some type of treatment.
Okay, that's a perfect segue to the next question, which is, what are prognostic factors, positive and negative, for recovery?
Well, if you are a male compared to a female, then you have a better prognosis. If you are older than 40 years of age, then you also have a better prognosis compared to if you had been younger, actually. If you've had a symptom duration of less than 7 months before you start to initiate treatment, and you also have a better prognosis. And if you only have unilateral pain compared to bilateral pain, then you have a better prognosis. Some of what I've been told in the past, and then it probably doesn't rely on research, was that BMI was also a strong prognostic factor, but it doesn't seem to be the case, at least based on research. And I think that one of the strongest prognostic factors that we have seen in our own research, and please bear in mind that the research that I've done has primarily been on the heavy slow resistance training as the treatment. And then what we see is that men simply respond better to treatment than women do.
And any idea why that is?
Short answer, no. So I don't necessarily know why, but I think it's the same pretty much across different musculoskeletal conditions, that men generally respond better to treatment and have a better prognosis.
Yeah. And we already touched on having a heel spur or not, so that's also not a prognostic factor. Right? And what about ankle range of motion? We also said it's not a risk factor or not consistently a risk factor. Is it a prognostic factor?
Not necessarily, no. It's not been found to be a risk, a prognostic factor. Some studies have indicated that it is a risk factor, but inadvertently we are treating limited ankle range of motion by using stretching, which we use quite a lot as a way of treating the condition. So, well, it's difficult to say whether or not what helps patients is that we're stretching the tissue, if we're stretching the plantar fascia, or if it simply just helps that we're increasing the ankle range of motion.
Ah, okay. And if we move on from diagnosis to treatment, and we start by often trying to relieve symptoms, I know you've done research looking at isometrics in heel pain that I think was based on Ebony Rio's study with patellar tendinopathy. What did you find out? Are isometrics effective in decreasing pain for plantar heel pain?
Yes, we tried to replicate the study that was done in patellar tendinopathy. We tried to use the same protocol, but of course we had to adapt it to another condition.
Yeah.
So at the time we thought that if it works for a tendinopathy, then it might as well work for a fasciopathy as well. So we used the same exercise, like it's a heel raise exercise standing on a step, and use that as the dynamic component, so dynamic exercise, the heavy slow resistance exercise, and then compared it to simply just standing in slight plantar flexion, and use that as the isometric exercise. And we also compared it to walking, and that was something that was, of course, not a replication of the study in patellar tendinopathy, but we wanted to see how good would exercise be if we compare it to walking, because many patients say that their pain improves when they start to walk. So we want to see if it would be worth it to perform exercises as a way of getting this acute pain reduction. So what we found was that there is absolutely no reason why you would use either exercise or walking, for that matter, as a way of reducing pain acutely. We only saw that there were in 20 patients, there were only 3 that experienced a clinically relevant pain reduction, and 2 of the 3 also experienced that in the heavy slow resistance training exercise. So they would just respond to performing exercises, no matter what contraction type you used.
Yeah, I really liked your research paper. I think this was also the first time I came across your name, so it was a nice paper to read. And okay, so if isometrics are not working or do not seem to work to reduce pain, what other options do we have? I have a list here that could potentially work, such as ice or ice and rolling, what people do, ibuprofen, taping. What does the evidence say, and what do you use in your practice?
So there is a lot of evidence, and the quality is variable. But there was a best practice guide that was published in early 2021. So they included both clinical expertise, but also patient values in their review of the literature. So it was Dylan Morrissey who was first author on the study, and they proposed like a stepwise approach, where you start out by, of course, giving patients information about the condition, and I don't necessarily know if they distinguish between patient information or patient education. I think it's important to do. One thing is just to give people information, but if it's going to be proper education, then we need to make sure that they actually understood what you told them. So it's a good idea to follow up and do a little. It's like what we do in education in general, right? There is an exam so that we know that our students have understood what we told them. So you should of course talk to the patients. Start out by doing something simple as stretching, using foot orthoses, and then from that you can build on further. You can also use taping because it can potentially give you a short-term resolvement of pain. If it doesn't work, then you can consider maybe using shockwave or corticosteroid injections as a way to move on. So that is that was the best practice guide. And in my own practice and in the research that we have done, then we start out by, of course, giving education, tell them what this condition means. If they have heard that they have a heel spur, or if they think they have a heel spur, tell them that this is not something that we need to treat, and it's not important whether or not they have a heel spur. We usually use just cheap over-the-counter insoles that we provide them with. It doesn't really appear that there is any evidence to support that you should use expensive customized insoles, and it's also, in my experience, it's very individual whether or not patients will prefer to have these very firm, rigid orthotics or something soft, silicone insoles, for instance. And again, there's no evidence to support the use of one specific type of foot orthosis. So I advise them. What we do, of course, in research, we give the same to them all. But when we've given them these soft insoles, we tell them that if they're already using another type of foot orthotic that they prefer, then they can just use that, because it's not important, and this is not like a miracle cure that we are giving them.
No.
And then what we have used is heavy slow resistance training instead of using stretching. So what you do when you do the heavy slow resistance training is that you're standing with the forefoot on a step. You roll up a towel to make the toes dorsiflex maximally, and then you do these slow and controlled heel raises.
Yeah, we also created a video, I think, a couple of years ago based on the Rathlev study that replicated exactly that exercise. And to go a little bit back, for example, in a runner, do you advise them to stop running, or should they keep running and decrease their volume? What do you tell them?
Yeah, they will often ask you whether or not they should completely stop running. And my answer would be, it depends. So it depends on whether or not you feel that it aggravates your pain. Either when you are being active, when you are running, or after your run, because again, they feel like if they get a warm up from the running, then they feel less pain. And then when they get back from their run, they sit and rest. And then when they get up, the first step pain is just much worse than what it was earlier in the day. But also monitor their pain the day after. But if they don't feel that it aggravates their pain more than what they consider an acceptable level of aggravation, then I tell them it's okay for them to continue to run. But if they feel that the amount of running that they're doing at the time is making their condition worse, or at least it's not making it better, then they should consider to tone it down a bit, do less running, do some activities that don't either compress or stretch the plantar fascia. Something like doing cycling, doing swimming, just to keep their same level of conditioning.
Okay, and if I look at tendinopathy, for example, what I often see is that at one point patients tolerate high load strength training very well. And at one point, people forget to implement stretch, shorten cycle exercises or plyometrics. At what point, or like the first question is, do you implement plyometric exercises as well at one point? And at what point do you do that?
Yeah, so we've not looked into it in research, and I haven't seen anyone who have implemented plyometrics for plantar fasciopathy at least. But of course, in Achilles or patellar tendinopathy, it's been used as like the last step before return to sport, because it builds capacity, which we want to do. But we also need to look into what are the demands of whatever we are rehabilitating towards. So if it's a runner, or in general like an athlete, what we do is that we of course see what are the demands, and I would always use something like that to improve the stretch shorten cycle before returning to play. but that is and that's not something just for tendinopathy. I think that it's important for every type of musculoskeletal conditions that our patients may have suffered from, to build capacity and hopefully decrease the risk of a re-injury.
Yeah, maybe that would be a nice study for the future to look at plyometrics for fasciopathy.
Absolutely, and also when to start to implement it, because it's also been discussed. And I know that Igor Sancho has a couple of years, in Achilles. Yeah, so maybe a next step for him or for me or some of my students could be to look into when to implement plyometrics for plantar fasciopathy as well.
Yeah, that was exactly the study that I had in the back of my mind.
I thought so. Yeah,
we also covered at one point. Yeah. Exactly. All right. I mean, we talked about a lot of stuff, and we are coming towards the end of the podcast. So I wanted to ask you: is there anything else that we haven't touched on, and that you would like to talk about?
Well, maybe we have already touched upon it, but I think that it's important to really emphasize that there is no strong evidence to suggest that one treatment is superior to another. Mm. So the choice of treatment really should depend on what your clinical expertise tells you, based on the patient that is in front of you and what you have had luck with in the past, and also again listen to the patients and what they want to do, and I think it's much easier to apply a treatment that they really believe is going to work for them. So if you strongly believe that this is the best possible treatment for them, then try to sell it the best way that you can.
Absolutely. Okay, so to finish the podcast off, Henrik, where can people find you if they want to know more about plantar heel pain?
I think
about you.
I think the best way to find me would be to go on Twitter and look for me there, because I try to give some updates on the research that is coming as much as I can.
Okay. We will certainly put your Twitter handle in the transcript of this episode, and if we put the episode on the webpage. And with that, I'd say, Henrik, thank you so much for your time and your knowledge. It was a pleasure to have you. And thanks a lot for everyone listening to this episode. To access the transcript and additional resources, make sure to sign up for a free Physiotutors membership on physiotutors.com, and also benefit from more useful physio content. If you enjoyed this episode, hit the subscribe button or follow our podcast on Spotify or Apple Podcasts, and consider leaving a review if you really enjoyed it. And with that said, this was Kai for Physiotutors, and I'll talk to you in the next episode. Bye.